Today, I'm going to feature a job that you probably didn't even know existed,
Huh.
and it is an option for PAs and NPs. The job that I'm talking about is called a peer to peer specialist. If you've worked in medicine, you have probably come across the dreaded need to have a peer to peer in order to get something approved by the insurance companies. So, my guest today is a PA who is going to talk about what exactly she does as a peer to peer specialist. She's going to talk about the team of PAs and NPs that she works with and how this is something that has really helped the organization and could be something that PAs and NPs start at their organization. But in addition to that, she's going to give some great tips on how to prevent having insurance denials in the first place, but also some things that you can do to quickly and easily get this peer to peer process done. You're definitely going to want to stay tuned.
My name is Paola Gonzalez, and I'm a physician assistant, and I've been in practice for over 20 years. My first job as a PA was with internal medicine practice with a Cuban physician, and he was great. But after a while, New York is one, it's expensive to live in, and it just
Yeah.
wasn't my cup of tea temperature wise, and I was ready to go. I went to Florida and I worked in a family practice, occupational medicine there with Florida Hospital. And then I ended up here in Texas in oncology, which is where I've been at for the past 16, 17 years. And it's been a really great experience because being able to work in various different specialties within oncology. So that's been very cool.
You must be at like a cancer specific institution, is that correct?
Yes, I'm in one of
Yeah.
the largest academic oncology centers. And
Mm,
so when I first started my journey, I started it with endocrine oncologists. And so I'm like, okay, well, I think I like this oncology. So I'm like, let me try something
yeah.
else. And so I said, I want to go do radiation. Now I can read a report and know what the heck is saying on there and how it
Yeah.
impacts the patient. And I said, okay, now I want to go really do more surgical and understand the
Okay.
process of reconstruction and all that stuff like that. So I went and I did GI surgery. So it was really
Mm.
cool because, like I said, we really subspecialized in a very unique aspect. And then eventually I landed at my current position because of those experiences.
That's what we're here to talk about today is your current position because it is pretty unique. And I think it's something that is both sad in a way that this position is necessary, but also a brilliant idea to start this position. So, why don't you tell us what it is that you're doing now?
In 2019, I was minding my business. I was actually working as a supervisor in radiation oncology at a different hospital center nearby. But I had previously worked, when I worked in GI surgery, I had worked with the business office and we were working on increasing access for the community and making sure we got those new patients in. So I had gotten a little bit of understanding about the financial aspect of things, the access aspect of the hospital and how all that works. And so a position had opened up with this particular new program that my hospital was trying to create, the current hospital that I work in. And the initiative was that they wanted to centralize the peer to peer process. And the reasoning behind that is because we were losing a lot of funds by unapproved testing being done and then not having it approved by the insurance companies. And the issues with that obviously were that clinical providers are so busy in their day to day just seeing patients. And so when you get an email from the financial team saying, hey, this isn't approved, you need to call this doctor like right now, and you're seeing patients, patients will take priority. And so what the institution decided is that they were going to centralize this and they were going to do this pilot program. And essentially, we would be the ones that would take over all of the process of doing these peer to peers. And so that led to the creation of this pilot program. And it was myself and two other nurse practitioners that started it. And it was our various experiences within the institution, as well as our healthcare knowledge, that allowed us to kind of really say, I think I can pick up a chart on a patient that I've never seen, review what is there, and understand why that imaging or that procedure is needed and advocate for that. And so that's kind of how this all started.
For people who may be watching this who are looking to get into medicine or just have never dealt with a peer to peer, can you tell us what a peer to peer is?
So essentially, what happens is when we as providers put in an order into our electronic healthcare record system, that goes then into the financial side of the hospital system or your office system. There, what they do is they take that CPT code and diagnosis and submit it to the health plan to say, hey, Mr. So and so needs this study for this reason. They on their side process it, and the way it normally works is they'll review it and say, you know what, this doesn't look like it fits the criteria. we need your doctor to call our doctor and explain why this is needed.
And for those of us who do work in medicine or have had to deal with this, we understand how frustrating that is you've spent your time with this patient, you've, made your diagnosis, you decided on a treatment plan, or you are needing certain tests to really confirm your suspected diagnosis. And instead of just being able to move forward and do those things, we have an insurance company that's kind of in the way saying whether they're going to pay for it or not.
It's been a really unique learning experience when we started with this program. We were walking in with a clinical provider eye, right? The same perspective that you just gave me, right? We just saw the patient. We know what we need for them. Why are you not giving us this? Like you're waiting, you're
Right.
delaying care. Like what's going on? So what we found over time was that there were certain criteria that these health plans were looking for, and it's not something that clinical providers know. And so as we started kind of figuring out how we were going to create this pilot, how we were going to create this program, we needed to then learn what are these health plans looking at when they're reviewing these things. And so we really started seeing that pattern of like, okay, there's this website, and within this website, there is actually this guideline that's very specific to whether it's back pain or whether it's pancreatic cancer or whether it's a headache. Like they have guidelines, and these guidelines, there weren't necessarily, not that I'm advocating for the insurance plan, but it makes
Right.
sense where they're coming from. So they actually do look at a lot of the different American Medical Association. If it's pediatric, they look at all the pediatric guidelines. For me in oncology, they're looking at NCCN, they're looking at actual, like they're really looking at a comprehensive list of references and articles to back up why they need you to do X, Y, Z before they'll approve test B. So it gave us a better understanding as to why we were getting these roadblocks. And it gave us a better understanding to educate our providers on what we needed from them to either document in their note or to give us the information that was not there, or to do a test ahead of time that might not be as expensive, that might still give you the same information. It's been a learning experience for our own providers to kind of be reminded of like, hey, maybe I don't need to keep just reordering what I always order, but let me really look at the guidelines and what is clinically necessary or indicated for this patient.
And as frustrating as it is for providers to face this stuff, and as cynical as I am about insurance companies, because I think that there are a lot of practices that they do that are need investigating. I'll just leave it at that. But uh, but I understand what you're saying, that we may be putting patients through unnecessary things just because it's kind of habit and it's kind of what is done. And this has forced your organization has faced it straight on and just like looked at the practices and looked at the guidelines and are working to help make things better for both the patient and the providers, but that also takes care of the business side because medicine is a business. There's no way to get around that. And you have to look at the financial side of it. So tell us a little bit about like kind of what your day looks like and what kind of things are you doing all day long?
And just to kind of step back a little bit too, how this has also helped is that, as you were saying, we're no longer having to impact the clinical team. When a peer-to-peer comes through, they don't hear about it unless we can't find the information that they need. So a day for me basically starts with before COVID, we had an office at the hospital system, and we all would, drive into work. Now, since COVID, our institution has actually become very hyper friendly. And so I go into clinic once a week where I see my patients. And then the other 4 days, my world is the peer-to-peers. And we do about 9,000 of these a year in our team.
Wow.
But we've also been able to essentially not only cover our salaries and that the institution was losing, I believe when we first started this, it's like 12 to $15 million at a time. And
Wow.
we've recaptured all of that. So grand majority of that. So there's definitely a value added to having dedicated providers to do this. And so I essentially every morning I log in. We have a work queue within Epic, which is the system that we use for our electronic healthcare record. And it tells us, okay, Mr. So and so needs a PET scan and it was ordered by this team and we need it by this date and this is the health plan. And so then we go into that case, and sometimes we'll get a reason for the denial. Like they'll actually give us the clinical guideline policy that's there. And then quickly we can go look in the chart and see, okay, what's the diagnosis? When was the last staging? What are they doing for treatment? And then I can easily say, yep, this meets criteria. They just probably didn't get this note or they don't know this little part. Let me call the
Right.
health plan. And for a while, we were doing it all ourselves. So we were calling the insurance plan, making that appointment, waiting for that provider to call us back. But we showed that it was an improper use of our time to spend 30 to 40 minutes scheduling an appointment. And so we were able to
Yeah.
advocate, showing data that we could get an AA, an administrative assistant, to help us with scheduling and stuff so that we could really focus more on the clinical decision making, whether the referral made sense or not.
Right.
So that helped us expand our process. And so now, like usually if I have a case, I've reviewed it, it makes sense. I will tell my AA, hey, go ahead and schedule this for me. The huge benefit of that is because there's only 5 of us that do this here in the institution, the medical directors that we're getting from these health plans are pretty consistent. They're pretty much, because we speak oncology, we're mostly speaking to a medical oncologist, surgical oncologist,
Yeah.
radiation oncologist. And so they now understand we're calling them. So we've actually garnered some partnerships and some collaborations, and the physicians themselves really do try to advocate. I think sometimes in the beginning, like they would be angry when we called. And
Yeah.
so now, because they know us and they know that we're not going to be all yelling upset when we call, or
Right.
calling because we have the information they need, it's made it so much easier from their side. Like they like talking to us because, one, we come armed with the information that they need to give the approval, and they want to approve. They really do. But it's helped because obviously there isn't that discord that a lot of clinical providers
Right.
feel with the health plan. We obviously are calling in because we truly believe that this patient really needs it by looking
Right.
at the information we have, and it just moves out the process. And so the providers don't never that's happening. The patients don't have to worry about the anxiety of like, oh my God, my pet's not going to be covered, or my CT is not
Yeah.
going to be covered. I'll have to pay for it out of pocket. Or let me explain to you why maybe you don't need this pet, but if you get the CT, the team feels that it's just as good. It'll give them the information and your plan will pay for it. And I think
Yeah.
sometimes when we educate our patients that way, they don't feel the need to have to do the most expensive test because they feel that's what's going to give us the best outcomes. Not always necessary. So it's been really beneficial from that aspect. And for me, it's a lot of flexibility in that I do work from home. I'm able to drop off my kids at school. And, when I'm done with my day, I can pick them up, and it's not dealing with an hour of traffic back and forth sometimes.
And so you said that's a team of 5 now, right? Are you all PAs or NPs?
Yeah, so we actually have 4 PAs and 1 nurse practitioner and an AA.
Yeah.
And then
Yeah.
our leader, who is our supervisor, he is a nurse practitioner, but she doesn't do any more of the calls. But she does a lot more of the logistics and the executive decision making, as far as, like, recently we're going to start adding on the high dollar drugs that our institution uses so that
Mm.
we help recuperate some of those high expensive costs.
Yeah, I'm curious, when you first, especially when you first started doing this, before you developed those relationships, did you receive any kind of pushback or any kind of issues being the PA doing the peer-to-peer with a, because I assume you're speaking with a physician on the other side from the insurance company?
No, you know what? They were pretty receptive. I think that we've really grown as a profession. Funny enough, I had one of the doctors that I talked to from Montana, and he was like, "Man, you know the guy does more than I do sometimes. We need to hire some PAs." But it's great that they see the value in our knowledge and the fact that we
Yeah.
really can be great providers for our patients.
Yeah, and the other thing that I had thought of was that I assume that you are seeing patterns that are arising and things that are missing from the documentation. And so is that part of what you guys do too, is go back and educate the providers?
Absolutely. So that's kind of been our driving force. And since we started, we had, like I mentioned, a pretty significant cost burden of having tests not being approved. And a lot of the times it was the documentation. What we found is that our medical directors at the health plans, they're not looking through the 3 pages that our healthcare system throws out at them. They go straight
Right.
down from the HPI and then down to the bottom to the assessment and plan section. And if the information they're looking for is not in either of those 2 sections, it's getting denied. And like a big one is they order a PET CT, and the health plan will be like, well, you don't have inconclusive CT findings first before we can get a PET going. Or you don't have documented contrast allergy. They're not looking at under allergy section of that whole 4 pages of records. They want to see it at the bottom. So what we've told them is
Okay.
like, look, if your patient can do CT contrast studies, at the bottom say, I'm requesting a PET CT for restaging due to contrast allergy contraindication. And that has
Yeah.
diminished some of that. Or they'll say, I'm ordering a PET CT because we had inconclusive findings on CT on this date. They don't have to give the whole findings. They just need to say those key words. It's the part.
Mm.
For example, for MRIs of the spine, like I know in urgent care, they may walk in and say, my back has been hurting. I've tried everything. And now you're like, well, let me do my exam. Let's order an MRI lumbar spine and see if you've got something going on, right?
Yeah.
The health plan wants to see that you've done an x-ray, that the patient has tried conservative therapy for at least 4 to 6 weeks. So they want at least 2 visits showing that you saw them for the initial time and that you did something and that it didn't help. So once you've got that, no problems. You've got your MRI. A lot of times the problem is we as providers, we're seeing them in an urgent setting or in primary care. We see them once. The patient can't keep coming back. And so it's documenting that, like, hey, I'm seeing the patient today for lumbar spine. The patient has already tried at home stretching exercises and they've tried Advil without relief, something like that. And I think if you just give a little bit more detail as to what they've tried, it helps a lot. So it's finding those key details in our documentation that could really make a big difference in outcomes.
It's great advice for any PAs or NPs or any clinicians that when they're documenting to remember that assessment and plan is a really great place to make sure that your thought process shows up there and why you're looking to do a certain thing. And then to kind of get familiar with guidelines, which is difficult, especially if you work in family practice. There's 1,000,001 guidelines out there. You can't be familiar with everything. But do they say kind of in those rejection letters why they're dismissing or not?
Yes. I will say there is one company, medical management company, because in general, it's not like it's Blue Cross or Aetna or United. There's obviously a bunch of different companies. But what these companies do is they hire medical benefits managers. And it's those benefits managers that kind of formulate those guidelines. And so Evacor, Carelong, and Evolent is the 3 main companies that most providers will experience or any of the other health plans because one of them they'll plug into. But they will provide you with your patient has been notified that this study has been denied because your doctor, either one, already has the information that they needed, meaning they just got a study done, you can't repeat it again, or you have not shown medical documentation to specify why this test is needed. Or, for example, if I get a brain one, MRI brain is very common for our oncology world. We're trying to rule out brain metastasis. If it's not something where the patient's like, there are no documentations that there's signs or symptoms of metastasis, therefore this test is not needed. So a lot of the times it's like, well, it's not needed, but hey, he's progressing all over here. So we think he might have something here, even though he's asymptomatic. So it's just highlighting the little part that helps kind of manage that. But what I will say is getting familiar with Evacor, Carelong, and NIH or Evolent guidelines. And you literally can go to clinical resources and it's a click down menu and it's super simple and it will populate those in PDF format for you and it will tell you what they're looking for based on what you need.
This talk has just really opened my eyes into things. It really makes me realize how much more streamlined and easier the process could be if you are going to write a note, look at the guidelines, make sure you've got the stuff in there to begin with. If you get a denial letter, then go look in the guidelines and see what you might have missed. Find some time in your schedule, have somebody else schedule a time for you, or if you need to immediately call. But within 15 minutes, you should be able to give them all the information they're looking for if you already know what they're looking for before you call. Because otherwise, I think the process is usually you get this letter and you're like, what the hell? and then you call and you're already, like you said, confrontational and you complain about it and then they have to pull from you all the information. You have to hunt and peck for it. So wow, that's 2 totally different contrasting ways to handle this. One is clearly better than the other.
No, it was a huge learning experience for all of us. So much that I have learned from the financial side, not only from the clinical decision making, is that test really necessary now that I look at the data, to the cost of some of these studies, particularly at hospital facilities. The difference between a hospital facility cost versus a freestanding facility is huge. And so, yes, I get the quality is important in that in some freestanding facilities, it may not be as good. But that's not always the case for every major center. Like here in Houston, we have very high quality diagnostic imaging centers just because of where we are.
Right.
And so I think there has to be a compromise in some ways because as a nation themselves, we are very, very expensive in healthcare and we are very corporate driven, unfortunately. And so a lot of the costs, unfortunately, fall back on the patient. And what I always advocate for is I just don't want the patient to feel that because the health plan didn't pay for it, they need to pay for it somehow. But
Right.
I also think going back to what you were saying regarding imaging and looking at the guidelines, if you work in ortho and you're consistently ordering an MRI shoulder or an MRI spine, you won't always have to look at those guidelines anymore because once you've seen
Right.
them a few times, like it's just in your head.
Yeah, make a little template up. Once you look at the guidelines, make a little template as you're looking at the guidelines, just do it once, and then you'll be reminded what all you have to throw in there.
I love my smart phrases for that reason. And it's a lot of little pull downs. It's like, okay, they've had it for 6 weeks, or we just gave 2 cycles of chemotherapy and we need restaging. And so now I've been more conscious about how I document because of what I learned from this position.
Now, you said that you work 4 days on this, and then so you still practice clinically 1 day a week. Is that what you said?
One day
Yeah.
a week. I love it because I still get that patient contact. I'm not gonna lie, I
Yeah.
do miss that. I enjoy my clinic days very much. I don't think I would be as happy if I was full-time financial.
Right.
So for anyone considering something similar, like I don't know if I would be as fulfilled if all I did was talk to the insurance company every day. Now I'm
Yeah.
advocating for a patient and I'm helping my patient indirectly in that I didn't see them in clinic, I didn't examine them. But if I took away that anxiety of having to pay for something and if they got
Yeah.
to their study without delay, that's my role.
Yeah, I could see how it would be nice to have a mix. I think that sometimes doing the same thing, no matter what it is, over and over helps lead to burnout. So your institution is a large academic cancer institution, but do you see this role being able to be useful in other settings? And have you seen or do you know of anybody else that is doing this?
I believe there's another cancer center in New York that is considering or maybe starting to do something similar. But I truly believe that this could be something that could be instituted in any major hospital center or a multi-specialty clinical center. I don't know if in a private care environment or in a private practice environment, it would be enough to do it because they are
Right.
not the ones billing for the diagnostic imaging themselves, like a hospital system would.
Oh, okay. Yeah.
And so it does impact hospital revenue and income and resources. But from a primary care standpoint or a private practice standpoint, I think the biggest takeaway from this is that if you get the guidelines, if you know how to document, you will bring
Yeah.
down the burden on yourself and on your peers on having to
Yeah.
deal with that. But like I said, going back to the original question, I think it can be instilled in any hospital system.
So if somebody thinks that this is a great idea and something that they think that they would enjoy doing, whether it be 1 day or 4 or 5 days a week, and they are interested about starting it in their organization, would you suggest that the first step would maybe talk to somebody in the billing office and find out if this is an issue, if they know that there's a lot of prior authorizations coming out and coming back?
Yeah, I think that the first step would be to speaking to the billing and recruitment specialist because they're able to see how many of those they're either having to write off, how many they're going to have to appeal. So understanding those numbers gives you the data to come back either to your medical directors or to your business managers and say, look, this is money that we're leaving on the table. That if you hire someone, and I can tell you that we get paid equally as a regular working clinical provider. So it does not
Yeah.
diminish your abilities to get paid what your salary is because you're paying for my brains and my skills, not just
Yeah.
for a body to call the insurance, right? That work will pay your salary easily if it's done
Yeah.
appropriately. And then finding that balance of understanding the different health payers that you're using, what medical benefits managers they're working with, and then understanding those guidelines. And once you have those pieces, the clinical knowledge is already there from our own profession. It's
Yeah.
just a matter of pulling them all together.
That's why I love to highlight like what you're doing and get people to start thinking about how they can help their organization, but also do something that maybe, like you said, shakes up their work week a little bit and gives them a little respite from seeing the large number of patients every day. Okay, any final thoughts that you have about peer-to-peer specialist job or anything else that you just want to share?
Yeah, I think, one of the things that I've gained now as a provider for 20 years and working from the clinical side now into this kind of mixed role is that it does open up a lot of doors for leadership opportunities. And it does allow for understanding of the financial aspect of the organization. So for me, it's allowed me to gain information that, somebody else that works in the breast medical oncology team may not have. So when I'm in clinic
And
and we're ordering something, my doctor will come like, hey, can we order that? Will the health plan cover it? And I'll quickly look at the health plan like, yep, it does. Let's go. Or like,
yeah,
no, we need to order this first. So I think it's given me a more robust understanding of the financial cost and burden of the institution and how it works. And it's
okay,
opened up some doors into some leadership opportunities that would have not opened up if it was just clinical work that I did. So it's, I think, a different pathway. I know a lot of people are looking into different degrees and into different certifications and how to get into more of the supervisory role and like leading others. But there's
okay,
also some administrative opportunities that as providers we bring to the table with our clinical knowledge and our history of seeing patients and what works and what doesn't, that the
yeah.
business side of things may not understand.
And once you get your foot in the door and they see you as on the administrative team or on the administrative side, it makes it easier, like you said, to progress into other roles. Well, thank you. This has been very eye-opening and very informative, and I appreciate what you're doing for the PA profession and also for just coming on here and educating us.
I appreciate the opportunity. It was always great talking to you.
If you'd like to learn about other non-clinical opportunities for PAs and NPs, I'll put that playlist here. And I also did another interview with Paola about her work with PAs for Latino Health, and I'll put that video up here. Thanks for joining me. And as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.